Welcome, Dr. Martin. It is a pleasure to have you here.
Great to be here today. How are you?
I'm great. I have a hankering to learn more about menopause. There has been more of an uptick about this topic on social media. There is less of a stigma around it. When I was talking to my mom about menopause, she was telling me her experience and how when she went to her gynecologist, he was like, "Oh, that's impossible for you to have the symptoms." The symptoms being mood swings, night sweats, things that we now know are really commonplace. But she said back in the, late 90s, she was dismissed a bit. So here we are in 2023. What's just the basics of menopause and perimenopause?
So first, to answer that question, let's first start out with pretty much the entire cycle length, our entire life history. So all women start, and I'm going to use women in just a kind of a generic term because that's where I've got all my data. We're not going to worry about, I'm not going to discuss specifically transgenders, anything along that line. But women in general start with very low estrogens, and at about age 12, more or less, they begin to increase those. As that happens, they develop breasts, they develop menses and other characteristics, and they start having periods and become fertile. That lasts for around 40 years. And then those levels of estrogen start declining. And the reason they start declining is because the estrogen is made by cells in the ovary that are designed to make them. And those cells start just, they don't wear out, but you've used all of them. They're just depleted. And as they decrease, the estrogen decreases, and all of those parts of the body that are estrogen dependent, which includes the ability to control hot flashes, to some degree concentration, bladder, vagina, a lot of things just start decreasing in their activity. And the hot flashes increase, and you go through menopause, and then there's no more estrogen and no more eggs, and fertility's gone.
Hmm. Okay, so that is the cycle of a female's reproductive life, essentially.
Yeah, without a lot of pregnancies in between, or no pregnancies in between. Yes.
And then what's the difference between perimenopause and actual full-blown menopause?
Well, perimenopause is all those symptoms that you get and all the changes that lead up to menopause. Menopause scientifically is defined as either 6 or 12 months of going without a period. The perimenopause generally starts about 10 years before that. So there's a decline of estrogen and egg production starting 10 years before true menopause.
Wow. Okay. So that means that's 10 years of potentially suffering with uncomfortable symptoms, like you said, hot flashes, mood swings. Weight gain is also a part of perimenopause, menopause, correct?
Yes, but I wish it were just those 10 years. It's not only those 10 years, but it's also the next anywhere from a few years to 20 or 30 years. I've had women who've gone through menopause and continue to have those symptoms for most of the rest of their life.
Oh.
So menopause doesn't stop the symptoms. If anything, it may exaggerate them in some women.
Okay. Well, that's not anything to look
I
forward
know, I'm sorry. That's one of those things I wish I had a better answer for. Some of the times I just hate the answers I have to give.
to. No, I totally get it. And then I want to add in another caveat, which is endometriosis and menopause. I have heard, and please correct me if I'm wrong, that those with endometriosis can have an earlier onset of perimenopause, menopause. Is that true?
Yeah, there are in fact reasons for that. The biggest reason for that is a lot of women with endometriosis have what are called endometriomas, or ovarian cysts that are filled with endometriosis. When they have surgery for those, the surgery that removes the cyst also removes part of the ovary. That decreases the overall egg mass, the overall estrogen production, and because of the decrease, then the natural decrease is added to that, and it makes women go through menopause earlier. The risk is such that if someone has endometriosis, they have about a 25% more risk of having early menopause than had they not had endometriosis. Most of that we think is related to surgery, but we're not sure. The best study on that was the Women's Health, one of the Women's Health collectives with several thousand patients, 106,000 or so. The problem is that that is a general database, and it didn't have specific information like ovarian cysts. So for the ovarian cyst information, we have to go to smaller studies to show that ovarian cyst surgery for endometriosis, but not for other benign cysts, decreases the estrogen production and increases and decreases the age at which someone will have menopause.
Well, we do know that endometriomas, which are commonly known as chocolate cyst and tied to endometriosis, that in itself, that kind of cyst can diminish egg reserve. That can affect someone's fertility. So would that almost have the same reaction conclusion that excision surgery would if someone had that cyst removed?
Let me try and rephrase the question just slightly.
Yes.
We're not sure if it's the cyst itself which causes the damage to the ovary or the surgery to remove the cyst. We anticipate that both are true, that the cyst itself does some damage to the ovary and removing it does more damage, but we're not sure of that.
Okay.
The second part is chocolate cysts include not only endometriomas, but also cystic corpus luteums, which are hemorrhagic. So if it's a hemorrhagic corpus luteum and somebody does surgery for it, then there's not a clear, I'm not sure I can explain a cleavage plane. If you were doing a tangerine orange versus a regular orange, can you separate the skin off of it? So that's a cleavage plane. And with a corpus luteum cyst, the cleavage plane is real clean. You do very little damage to the ovary. It comes off very easily. With an endometrioma, it's almost like it's attached to the ovary and it doesn't want to let go. So it does more damage to the ovary. And that's the reason that endometriomas damage the ovary and decrease the age at which you go through menopause more than simple cysts, which would be a hemorrhagic corpus luteum cyst.
And that's without surgery, that an endometrioma would damage someone's ovary, correct?
We think both are true. Yes,
Okay.
that's correct. And the other is also correct. So it's a combination of the two. Yes.
Wow. Okay, that's intriguing, and that also makes a lot of sense why that would be. So those are our correlations for why those with endometriosis could have an earlier onset of perimenopause and menopause. What is the average age that someone will go through menopause?
Currently, it's around 51 or 52. I haven't looked it up recently, but the last numbers I remember were right at about 51, 52.
No, okay. And then perimenopause would be anything on average before that. So like 40 years old, about.
Yeah, 40, 41, 42, about 10 years earlier. Yes.
Okay. And what would the classic symptoms be?
Well, the ones you mentioned earlier: hot flashes, night sweats, mood swings, vaginal dryness, breast getting smaller. Just generally anything that's estrogen responsive is going to get is going to not function as well. But on the other hand, that's good for endometriosis because that means that endometriosis tends to go away also.
Right.
Almost all the endometriosis we find in postmenopausal women is asymptomatic. It's just sitting there because it's inactive. One of the reasons that we need to be aware of that is because if someone is menopausal and we know they have endometriosis, then we have to be very careful about giving them estrogen for their menopausal symptoms because it can activate the endometriosis.
That was my next question. Hormone replacement. So when you have someone who does not have endometriosis, would you recommend, and of course, this is generally speaking, you're not treating anyone in this conversation, but if someone is going through menopause and their hormonal levels are depleted, let's say their estrogen is extremely low to almost non-existent, their progesterone is extremely low, would you think it's best that they have hormone replacement therapy to help with their symptoms and make sure that they don't have bone loss?
Let's talk about three different issues there.
Mm-hmm.
One is the bone loss, one is symptoms, and three is menopause. The three don't always go together. Some women go through menopause with almost no symptoms.
Lucky.
And if you go, yeah, you're right. Yeah, I agree. I wish we could bottle that. Put it in a bottle and just hand it out at the corner. Those women are probably better off avoiding hormones because all the hormonal therapies are associated with side effects. Some of the side effects are physiologic, like estrogens can cause breast tenderness and that sort of thing, just like they can cause breasts to get smaller if there's not enough. Some others, like hypertension and strokes and those kind of things, are associated with combined birth control pill use. So you want to watch out for using estrogen and progesterone both. And if you have endometriosis, you almost have to use those unless you can get the estrogen at a low enough level that it will control the symptoms without getting above the estrogen threshold. The estrogen threshold is an old concept that says that women can respond at very low levels under certain circumstances that are low enough that they won't activate the endometrium and won't activate endometriosis.
Okay. So, and that's a tricky balance to find, I would imagine.
Sure can be, particularly it's like if for those of you who've seen my monograph on endometriosis concepts and theories, it's the cover picture of that. A 43-year-old who we were operating on her because we were afraid she had cancer. This is a medically sophisticated person who works in the hospital and did not want surgery at all, wanted to stay away from surgery. We thought she had endometriosis for a long time, but she didn't want surgery, didn't want to know. She said she could deal with it. And then all of a sudden she had a dermoid cyst, and we weren't sure if it was a benign dermoid or a cancer. So we have to go after the dermoid, and we decided while we were there doing the dermoid, we would also do her endometriosis. What we didn't know is it was also hooked to the bowel. So I removed everything that was not attached to the bowel, removed all the endometriosis and left that area on the bowel. And then when she went through, she's 43, 44 at the time, when she goes through menopause, it was very hard to get her hormones correct because we couldn't use estrogen alone because we knew we had endometriosis there and could activate it.
That see, that's the tricky part. So
yeah,
with endometriosis, I've spoken to other people with the disease, and they've said, I can't wait till menopause. I just can't wait that my endometriosis goes away.
Be careful what you wish for. Yeah.
Right. But my question has always been, okay, well, I've heard it's dangerous to not have enough of estrogen, but as a doctor once called me a ticking time bomb if I didn't suppress my estrogen with endometriosis. So I'm like, okay, so how, like, what's the solution? It seems there doesn't seem to be a clear path forward for endometriosis and menopause.
Nope. Wish I had a better answer than the one you already know, but the one you know is correct.
So by giving hormone replacements such as estrogen to someone who's going through menopause as a person with endometriosis, are you also belaboring or delaying full menopause to happen?
Then you get into definitions.
Okay.
Since the definition is dependent upon the egg depletion, you can't stop egg depletion. Egg depletion is a natural phenomenon. It's going to go on no matter what you do. Birth control pills don't stop it. Hormones don't stop it. Pregnancy doesn't stop it. Nothing stops it. It's just going to happen. It's part of life. It's just part of getting old. And as you understand, I'm older than I want to be, and I wish getting old was not a part of everyday life. But getting old is getting old. If you can figure out some way not to do that, I want to buy it. I'm ready to buy it right now. But that's just going to be part of getting old. I wish I had a better answer for.
But there's no way to, I guess my concern is if you don't have, I mean, I guess it's, so people with endometriosis, do they just have to deal with the symptoms of menopause?
Oh, no. You can, with endometriosis, if the menopausal symptoms are bad, you use both estrogen, progesterone combinations like birth control pills rather than estrogen alone, or you can start with progesterone only pills. In theory, you'd always start with progesterone only pills to avoid the estrogen, But the problem with that progesterone only is it has increased chances of problems with oily skin and acne and that kind of thing, which nobody likes
And
either.
also weight gain and all
And
that
weight gain, yeah,
stuff.
yeah, a whole bunch of things. Yeah, you got
Yeah.
them. So we use the estrogen to counteract the progesterone. Now, if the estrogen hypothesis, the threshold hypothesis is that as long as you can keep somebody below 0.625 equivalent of estrone, that you can control bone, some hot flashes, and not activate endometrium. So as long as we can use a really low estrogen pill or a low estrogen combination with something like estradiol, then that will sometimes work if you're lucky. You got to be lucky for that to work. But if it does, then you can get everything where you want it to be.
When you were practicing, let's say in the 70s and 80s, and now what you're seeing, even though I know you've since retired, but do you see menopause being less stigmatized as it was? Do you have any examples of what was shocking to you back?
Oh, you got to remember, I was as you understand, I was trained by my father to be a physician. I was doing house calls at 12 years of age. So
Wow.
I was talking to his nurse about what in the world does menopause means when I was 13 or 15 years old. Uh, this for me is just the concept of it being stigmatized for me is kind of, it doesn't make sense to me because I've never been there. I'm like Whoopi Goldberg. Remember her first
Yeah.
sentence when she
Yeah.
does her thing? She never thought endometriosis was a problem because when she had it, her doctor said Buddha Bob Bada Bing, whatever that is that Whoopi Goldberg says, and he fixed it and it was taken care of. So she thought it was no big deal.
Mhm.
There are a whole lot of women who get to be that way.
Right.
So it's stigmatized in general. There's a lot of normalization of pain and those sort of things in general. But a
Mhm.
lot of that stuff, I was trained to take care of things. Just, if you're trained to take care of things, then you don't normalize much of anything. You just go after them.
Right. Well, I think you were progressive in your thinking, from what I've heard from others.
Well,
And they're
but there's more to it than that. I got lucky. If you look at one of the best papers out there, that Stahl paper, it shows that 25% of patients with endometriosis have a diagnosis at less than 18 months.
Hmm.
Okay. But at the 50% level, it's 8.3 years. And at the 75th percentile, it was almost 14 years. And some women in that study took 30 years. So just a wide range of
Right.
how people are doing things. And I was lucky enough that in 1970, I was trained by a physician who took endometriosis very seriously and trained us to take it seriously. You hear a lot about medical students aren't trained anything. That's where I got my training, was in medical school.
Mhm.
Uh, Medical schools have courses in this, but there's just a difference in it's not just the course that counts, but it is the orientation of the people teaching it.
Right. No, that makes a lot of sense. And
Yeah.
also you can choose specialties as well when you're in medical school. And I've met people who
So, you
well,
can
as
you
you,
can
I'm
you
not, I'm
can
not talking to you. I'm talking to a general audience. I know you know. But you can also choose like secondary specialties. So let's say you want to become a cardiologist, but you also have an interest. Like I have a friend who's a brain surgeon, but he also had a secondary interest in learning about women's health. So he learned a lot about endometriosis because that was essentially his minor.
yeah.
Um, and he knew a great deal, but he was brain surgeon. So it really is also, like you said, who's your professor, what they're going to be putting their attention to, what interests them as well, and
Yeah.
then other things that you're pulled to. So like you said, it is how you get exposed to things. But in general, I'm hoping that people are more knowledgeable about endometriosis and menopause, and as they impact each other, and how people can find the proper solutions for themselves so they don't have to feel overall generally crappy going through it if they're having symptoms. So thank you so much for joining us today, Dr. Martin.
Thank you, Diana.